I'm now pleased to welcome Director Pat Allen, who heads the Oregon Health Authority and who will provide our opening address, No New Normal, Promoting Health Equity in a Pandemic. Director Allen has over 25 years in public service, and his guiding principles at the Oregon Health Authority are to promote transparency, the wise use of public dollars, and integrity throughout OHA's many programs. If you have questions, please fill them in the Q&A box, and we will have the opportunity to speak with Director Allen after his presentation. Thank you.
Thank you. Oregonians are today confronted by the COVID-19 pandemic, which threatens the lives and livelihoods of people across the state. As physicians and healthcare providers, you're confronting the greatest health challenge we can expect to see in our lifetimes. In the same way, we're facing the greatest challenge of our lives as public health officials and healthcare policymakers at the Oregon Health Authority. At the same time, Oregonians are grappling with a national reckoning over systemic racism and inequity. As healthcare providers, this is an opportunity to confront and interrupt the unacceptable inequities communities of color have experienced in healthcare, just as we are reckoning with our responsibility to acknowledge and interrupt those inequities in our role as policymakers, payers, and regulators at OHA. Today, I'm going to talk about four things: how we define health equity, how the legacy of inequity in Oregon has affected people's lives, how the COVID-19 pandemic has laid bare these stark inequities in ways we can no longer ignore. And finally, I want to talk about what we're doing as a state to tackle systemic racism in our pandemic response. OHA's mission to help every Oregonian achieve optimal health and well-being and ensure access to quality, affordable health care has never been more urgent. But health equity has been our priority even before the COVID-19 pandemic, starting with our strategic plan. To fulfill our mission, OHA is developing a strategic plan with a singular overarching goal: to eliminate health equity in Oregon over the next 10 years. This strategic plan has been developed with the input of hundreds of Oregonians throughout the state, with a primary focus on listening to people from communities that have experienced health inequity and who our health system has failed to serve, as well as white residents. It's an ambitious goal, but we can achieve it by working with you and other partners. But before we get into how we're working to eliminate health inequity from our COVID-19 response, let's talk about what we mean by health equity. Let's go to the next slide, please. What I want to do now is do a little bit of definitional work and talk just briefly about the distinction between health disparities and health inequities. In simple terms, health disparities are differences in health that don't have an underlying issue that it calls for a policy response. Best example I can think of is the difference in birth weight between boys and girls. Boys on average weigh a little bit more than girls do. There's nothing about that calls for action or indicates a particular problem. Health inequities, though, basically are unnecessary and avoidable. They're considered unfair and unjust, and usually they're rooted in social injustices that make some groups more vulnerable to poor health than other groups. Again, the best example I can think of here is infant and maternal mortality in Black mothers and babies versus white mothers and babies. Black mothers and babies die at significantly higher rates even after you've adjusted for income and educational levels. Let's go to the next slide. But what does health equity mean? In Oregon, we have a definition that establishes what we mean when we talk about health equity. And I'm not going to read through the definition here, but I do want to highlight some of the key terms. Health systems create health equity. Health equity and inequity are products of a system. Health inequities are not the products of personal responsibility. As providers and policymakers, we've got a profound impact on the health system. We have the ability to interrupt systemic racism or perpetuate it. As an example, when Oregon provided health coverage to every child, regardless of their immigration status, the state addressed a structural barrier that fueled health inequity among Latino families. Ongoing collaboration. Too often we treat health as if it's isolated from the larger social context. Instead, we need to address health in a broader social context. That means partnering with communities in different ways, addressing housing, education, food security, poverty, and other issues that account for 90% of the factors outside the doctor's office that impact a person or a family's health, in addition to the 10% that a provider can address. Redistribution of resources and power. We have to listen in new ways and genuinely share decision-making power, historical and contemporary injustices. We have to recognize that the legacy of genocide and slavery still exert a profound impact on the health of Native Americans and African Americans, and take action to mitigate the health and social burden of these injustices. Next slide. Actually, the slide after that as well. So I'm not going to go into a great deal of data or of detail on these data slides, but what I do want to do is quickly share with you some data points to illustrate this notion of what these inequities are and how they track to past and present injustices and racism. Here, I've got 4 data points. The upper left-hand corner is adverse childhood experiences, ACEs. I'm sure you're familiar. And this is an indication of the fact that American Indian, Native Alaskan children are about 50% more likely to have suffered 4 or more adverse experiences in childhood. Graduation rates on the right side, substantially lower in the same population. Homelessness in the lower left, significantly higher among African Americans. Incarceration rates, vastly higher among African Americans. Next slide, please. Black and Hispanic Oregonians are less likely to have health insurance, and we're seeing the impacts of this play out in dramatic fashion, especially in the coronavirus pandemic, as access to and connectedness to not just insurance, but the primary care, particularly that insurance helps pay for, plays out in incredibly high infection rates amongst Latinos. Next slide. Many communities of color report higher average days of poor mental health. And this tracks, again, along the same kinds of lines of American Indians, Alaska Natives, Black Americans, Native Hawaiians, Pacific Islanders, all with significantly higher days of poor mental health. And what I want to point to across the bottom, we've identified some of the key drivers. And it's this pervasive notion of getting up every day and being faced with socioeconomic status, job issues, daily racism and encounters, and then particularly unequal access to healthcare services. Next slide. And this then is kind of the flip side of that, which is the ability to access behavioral health services. And here I want to call out linguistically and culturally appropriate services as a barrier. If you get east of the Cascades, it's incredibly difficult for a Latino individual or family to be able to get behavioral health services in their language in a way that respects what culturally works for accessing those services in their communities. Next slide. This is regarding aid and assist patients, and what this is a legal term, and it's people who have been arrested but are unable to participate in their defense because their mental condition makes them unable to aid and assist in their defense. And so they require restoration services before they can stand trial, if in fact they ultimately stand trial. And here, the point is that Black or African Americans are much more likely to be involved in aid and assist restoration services than others. Next slide, please. This indicates the challenge Black and Hispanic parents have in getting their children needed care. And this, believe me, is not because Black and Hispanic parents love their children less or recognize the need for care less. It really stems from access to, again, linguistically and culturally responsive services, access to payment through insurance systems, and then conscious and unconscious bias. I'm sure you've heard the story of Serena Williams and her experiences during childbirth, basically having a blood clot. She had blood clots before, recognized the symptoms, and couldn't get her caregivers initially to pay attention to her symptoms. Next slide. Finally, this is the one that is most profound to me and really kind of wraps everything up. This is a little bit of a wonky metric, but it's the years of potential life lost before age 75 per 100,000 people. So in a population of 100,000 people, how much premature death is there, and how significant is that premature death? And it's striking and tragic and shocking as you look at these numbers again of American Indians, Native Hawaiians, Black and African Americans who lose double the amount of life as white Oregonians. We've listed some of the major causes on the right hand side, and really these these track very closely to causes related to toxic stress. And so this is not sort of a matter, as I indicated in the beginning, of a bunch of bad personal choices for no reason at all. This is the accumulative burden over generations, in particular for these populations, of the impacts of slavery and genocide. Let's move to the next slide. So let's talk about the ways COVID-19 has made the inequitable health burden of people of color worse in Oregon. Next slide. This is stuff that I think we've all been hearing and reading about, but I want to show you the numbers in terms of disproportionate impact of coronavirus. This is infection rates. And in fact, the most disproportionately impacted community is the Pacific Islander community, which is relatively small in the state, but you can see at nearly 350 cases per thousand is just off the charts in terms of impact. The Hispanic community, much larger, but also extremely disproportionate, particularly, pardon me, in our rural communities. Next slide. As we've moved from spring to summer, we've also now seen a shift that's been well documented in terms of age of cases. On the left-hand side, we look at hospitalization rates, and you can see that they track closely to age. On the right-hand side, however, the numbers of infections, the case rate per 10,000, skews very, very young. 20 to 29-year-olds, 30 to 39-year-olds in particular, 40 to 49-year-olds. Now, when we see this figure, I think we're tempted to think of college kids in Florida partying in bars and things like that. And to be sure, there's an element of that, but we're also really talking about the workforce. And in this case, if you interface this number with the Latino numbers, what you're talking about is a workforce that's disproportionately in frontline or essential jobs, where they're in high density employment like food processing, or high exposure jobs like long-term care and those kinds of things. So there's a lot wrapped up in that statistic. Next slide, please. Now, this really, I think, just captures what I talked about a minute ago, but underlying conditions really are what are driving bad outcomes, particularly for Black and Pacific Islander Oregonians. And if you go back to that, the data on years of life lost and the underlying causes, they're really very, very similar in terms of hypertension, diabetes, obesity, and those kinds of things. Next slide. So we at the Health Authority need to operate differently. Our 10-year goal is to eliminate disparities. We can only succeed if we work in partnership, not only with healthcare providers, but with the community. Both providers and health policymakers are contending with historical distrust. The government role in perpetuating systemic racism in law enforcement, education, housing and economic policy, healthcare, legacy of medical experimentation, the legacy of lack of access and quality of care. Typhoid blankets given out to Native Americans is a fresh event in the collective memory of tribal communities, as an example. And of course, the Tuskegee experiment, syphilis experiments, again, a fresh event in terms of the willingness of Black Oregonians to trust healthcare providers. Let's go to the next slide. So there have been some specific equity challenges as we look at responding to COVID-19. I talked about restricted access to healthcare. Given the disproportionate impact of coronavirus on the Latino community, what's especially become a barrier is not only the generally lower rates of access to health insurance and thus healthcare, but also the citizenship status of people who are being impacted, skewing very heavily to people who don't have legal status in the country. I talked about the step that Oregon took about 5 years ago to make sure that we've got access to the Oregon Health Plan for all children, regardless of their status. We don't have a corresponding program for adults, and thus we have lots of adults who don't have a regular connection to healthcare. Another big problem that we've had is the ability to effectively isolate and quarantine. And this is really tied to the economic circumstances and that socioeconomic disparity that occurs, where you've got people who, again, don't have status, need to go to work each day to feed their family, don't have access to some of the same supports that that white or other Oregonians have to be able to pay them to stay home and effectively quarantine. And we've seen this play out in really, really high infection rates in places like Umatilla, Morrow, Malheur County, Marion County, as it's been very difficult to be able to overcome those economic imperatives. I've talked a lot about language and communications barriers, and then that fundamental distrust of government agencies. If you flip from the history of disease and interactions with medical professionals in the Native American and Black communities to current experiences of Latino Oregonians around government agencies, questions of immigration status being picked up and deported, having access to any services be counted against them in proceeding through, gaining legal status. These things all build up to create a circumstance where their willingness to trust local public health or state public health is very, very low. Next slide, please. And really, when we think about our COVID-19 response, we think of a variety of dimensions to it, and we need to make sure each of those dimensions addresses equity. I won't talk about each of these, but data collection I do want to talk about, because we're going to be calling on you at some point in the next several months to begin providing information about race, ethnicity, language, and disability in different ways than you have previously as providers. This is based on legislation passed by, a bill passed by the legislature that begins to go into effect on October 1st and tries to do a much more comprehensive job of more accurately collecting this data than the standard census categories do. For instance, breaking Asian into more meaningful subgroups that have a much stronger connection to what the underlying challenges are based on that. I also want to touch on vaccination. We're going to have some big challenges, I think, when vaccines become available. I've heard it said, and I've been repeating a lot, vaccines don't prevent disease, vaccination prevents disease. And we're already in a state that has a high rate of vaccine hesitancy. Again, hearkening back to times of medical experimentation, we've got some barriers in front of us when we think about the fact that there are populations that already have a tenuous connection to healthcare, distrust of government sources, and yet need the vaccine more than other populations do, because that's where the most spread of disease is. It's a huge issue. Next slide, please. Part of what we've done to address this problem is think differently about how we engage with communities that have a history of racism, oppression, and disproportionate impact of disease, and this history of lack of trust. And so we've worked with now 170 or 180 community-based organizations to help us in our response to COVID-19, to be the front line, to be the face of the response, because they're in community, they're trusted partners, they're trusted voices, and we can work through them to be much more effective collectively as a system in dealing with this whole range of issues that we've talked about. They're organized all across the state and have really significant ties in their communities. We, in fact, have just awarded about $45 million in mini grants to a couple hundred of these organizations to do all those basic things I talked about in terms of food security, housing, other kinds of cash assistance, childcare, whatever it is people need to be able to, that exist as barriers, especially to effective quarantine and isolation, which is the number one tool we need to be able to gain control over the pandemic. Next slide. Those $45 million grants, we've tried to track to basically the prevalence of coronavirus. The money is on the right-hand side. The prevalence is on the left-hand side. And so we've tried to break out of an ordinary mold. This was a fairly controversial investment the legislature made when it finally approved this. And it was because we didn't go through the ordinary process of do us a detailed proposal, line out exactly what's going to get spent where, and all those kinds of things that become structural barriers to the organization's best positioned to be able to provide this assistance. Next slide, please. And finally, we've tried to really change our organizational response and how we approach communication. Our first COVID-19 case was confirmed on February 28th. Since then, we focused on making sure that health information, guidance documents, and other materials are translated into multiple languages. Since the 28th of February, we've produced more than 5,600 documents. That's actually more documents than the CDC has produced in that period of time. Each of those documents, almost all of them, have been translated into 11 different languages. Translation is vitally important, but we also want to make sure the translations are timely, and our goal is to make sure we've got those 11 languages translated within 24 hours of putting out a document. We do Spanish language simulcast of our news conferences and Facebook Live events. Those have reached as many as 24,000 Spanish speakers at a time. We have our staff engage on Spanish language radio. We have a Spanish language Facebook page that's not just our regular Facebook page translated into Spanish, but it's the it's natively created as a Spanish language site, and so it's got some differences. Next slide. We've also prepared specific response plans that are directed specifically at individual populations that are, as I've gone over before, those most directly impacted. Next slide. And so even though it's not going to be easy, this focus on health equity in the coronavirus response, and as we come out of the coronavirus response into our general work as an agency and as a health community, is the right thing to do. If we can eliminate health inequities, we improve health for everyone. A good example of this is how a curb cut in a sidewalk makes that sidewalk easier to navigate, not just for people with disabilities, but parents with strollers, seniors using walkers, workers pushing carts, and the list goes on and on. Now that we've got this 10-year goal, we're going to be developing 3 to 5 year plans for how to get there from here. Then we'll take those goals back out to tribes, historically underrepresented communities, and providers like you, and ask if we're on the right track. It means changing our policies and practices, and we're going to make a lot of mistakes along the way. And there are going to be a lot of voices that resist change. As you go out and try to talk directly to people without kind of beating around the bush about the effects of racism, about genocide, about slavery, people react viscerally to that and push back, and we're going to need to overcome that. Finally, I hope that you'll join in working to eliminate these health inequities. As I said earlier, if we can eliminate health inequities, we improve health for everyone. That's why we as a health authority were created. It's what we're here to do, and we look forward to working with you to do that. Thank you.
Thank you, Director Allen, for your presentation. We have a few minutes to go through some questions from the audience. I appreciate Director Allen being able to answer some of those questions during the chat, but I'm gonna go ahead and ask some of them, and we'll hopefully be able to get your response live here. All right. So the first one is, let's go with how has dependence on employee-sponsored health insurance influenced the distribution of COVID cases in Oregon?
Yeah, thanks. And I tried to answer this a little bit in the Q&A at a point where I was having a hard time figuring out how to work that part. But one of the challenges is the highest incidence of COVID has occurred in populations that are least likely to have health insurance. And this has had all sorts of ripple effects. So if I understand what the questioner is getting at, our dependence on employer-based health insurance in a system that doesn't require employer-based health insurance, across the entire workforce has created real barriers. We've also got challenges with the same most at-risk populations having citizenship status concerns, making it difficult for them to access coverage through other means. And so really it's the breakdown of connection to primary care that I think is one of the biggest barriers we face.
Thank you. Next question is, what have some federally qualified health centers done to reach out to patients of color, especially when an area is predominantly white and poor as well? The question asker comments that we are in Redding, California, and serve some 30,000 poor patients that are mostly white, but we still need to reach out better to our patients of color.
Yeah, I'm not sure I've got a good answer for that one based on my own experience working with our FQHCs in the in the most impacted populations. I can't think of areas that have a similar demographic to Reading that also have a really high incidence of COVID. So I don't know that I have a good example to be able to point to there.
Okay, thank you. And then next question is, how has OHA done outreach to primary care providers to help manage confirmed COVID-19 cases?
Yeah, so I'll answer that in a couple of ways. In terms of outreach to primary care providers, we have regular online provider webinars that have focused on whatever the most recent and topical issues are throughout the pandemic, to give people an opportunity to ask questions, hear from our experts, those kinds of things. And if we haven't already, I can make sure the association's got the information about how to log on to those and can circulate them to members. In terms of connecting primary care to cases, there are a couple of ways that we're working to do that. First, again, we got the basic barrier of we're often dealing with people who don't have a primary care provider or a connection to primary care. That's a challenge. Coordinated care organizations in Oregon are an important piece of that connectedness, and we've been working with CCOs and their provider networks to try to help deal with that. That has got the challenge that's related mainly to the Medicaid Oregon Health Plan, and again, much of the most impacted population isn't eligible for the Oregon Health Plan, and so we've got some layered problems that are a challenge. But I think those are probably the two main things I would point to.
Great, thank you. And then the next question is, how will the state of Oregon address the large inequities and disparities of our mental health system as it compares to our physical health systems? You talked a little bit about how east of the Cascades, there's really very little mental health kind of culturally appropriate, and I think the questioner is curious what we're doing about that.
Yeah, so it's interesting. In addition to what I put in the Q&A box, there's been sort of a revolution in telehealth as a result of the pandemic. And going into the pandemic, I think we had often pointed to telehealth as a promising way to be able to deal with some of these language and cultural barriers in remote parts of the state where it's really difficult to get a Spanish-speaking psychiatrist in a small remote community, but through telehealth we can get services from a Spanish-speaking psychiatrist to that remote community. What we found as telehealth rates have skyrocketed through the pandemic is that equity concerns get raised rather than answered, and it's really around access to technology, connectivity, those kinds of issues. And so I think one of the things we've learned coming out of this is we need to deal with both sets of issues. We've got to be able to expand the pool of providers to serve communities, and we've got investments in health education to do that, including expanding the use of peer supports and other community health workers as a way to build out that workforce. And then we also need to be able to figure out how to use telehealth, not just in terms of where it gets sent from, but how it gets received and is able to be accessed by a variety of communities. Great,
thank you. We have time for just one more question. I really appreciate all of the questions coming in, but this last one, there's been several comments in the chat from Dr. Gaudino, and I'm going to read one of his most recent questions, which is, while I applaud the investment to CBOs to address real on-the-ground issues and impacts for Oregon communities due to COVID, this is amazing, but again illustrates my point about how public health at the community level is ignored and underfunded. Local and tribal public health have the expertise and training to help communities implement evidence-based public health interventions. What is the role, if any, of local and tribal public health in these efforts at the community level?
Yeah, thanks. It's a great question, and I think you made Doctor made the comment in the Q&A earlier. Oregon went into the pandemic with probably the 47th or 48th lowest funded public health system in the country, and turns out that's not a good thing to go into a pandemic with. Local and tribal public health is critical, and that's why during the time I've been at OHA and over about the last 4 years, we've really been making a big push to increase funding of public health through public health modernization. So not only put more money in the system, but put more money in a system that's structured in a way that's different than the traditional. This disease gets this many dollars and that disease gets that many dollars kind of a structure. And we've had some pretty good success. It's also been challenging explaining what public health modernization is to policymakers, and I think now they've got a much better idea of that investment that you make in local public health to be able to case investigate and contact trace tuberculosis or chlamydia or something like that is the same infrastructure and skill set that you then need to be able to ramp up to be able to deal with coronavirus. And so in all of these cases where we've made investments in these 170 or 180 community-based organizations, we require an MOU between the organization and local or tribal public health working in the same area, so that the nature of the relationship may vary widely across 33 different public health authorities around the state, but that there is a structure to that relationship and a set of understandings and accountabilities back and forth.
Great, thank you. I know we have a wonderful presentation coming up on public health and the importance of engaging, so hopefully we can have some more good conversation about this. But we do have to wrap up. Director Allen, thank you very much for joining us. It looks like several more questions have popped up in the Q&A. If you're able, we would love for you to do your best to answer some of those in the chat after we move on. But thank you very much for joining us today.
Thanks for having me, and I'll dive back into the questions and do my best.
Great, thanks.